Today I am sharing with you a very important topic, which is does varicocelectomy improve semen in men with azoospermia and clinically palpable varicocele? First of all, I have no conflict of interest to disclose. Then, as we know, infertility affects around 15% of couples worldwide, where men are responsible for around 50% of these cases due to various causes like pretesticular, testicular, and post-testicular. I won't go in depth in this because it will be covered by my colleagues, Dr. Wael Zuhdi and Professor Medhat Aimer. But however, we can definitely agree that non-obstructive azoospermia is the most severe and most challenging case in male infertility, and it's present in around 10% of infertile men. In the past, these men, and when I say in the past, it's 30 years ago, had no options for reproduction other than donor sperm or adoption, which is even not accepted in our culture in the Middle East. But in the 90s, with the discovery of the small foci of active spermatogenesis within the testicles of non-obstructive azoospermia patients, and the ability to retrieve them by testicular sperm extraction and then coupled with ICSI, these patients at last had their chance to father their own biological children. However, this treatment doesn't come without a cost. One of the major side effects, as Dr. Silber said before, was testicular injury. In these cases, sometimes we need to do extensive dissection to the testicle to try to find this tiny foci of spermatogenesis, which may cause devascularization of the testis, leading to testicular injury and testicular atrophy. And it may also lead to hypogonadism if Leydig cells are massively affected by the dissection. So the patient will later on need testosterone replacement therapy. The worst drawback of testicular sperm extraction is the failure. I think you will all agree that one of the saddest moments in our life as andrologists that when we do microsurgical testicular sperm extraction for a patient, and after 3 and 4 hours of search in the IVF laboratory, the results comes at negative. This causes a devastating psychological and social effect on the patient and his wife. Us as andrologists have, and all over the world, have exhausted all our science trying to improve the sperm retrieval in this subset of patients. One of the methods was the medical treatment. Although there are no guidelines and there is no clear benefit out of it, but it's still widely used all over the world. It includes either estrogen septum blockers like clomiphene, citrate, or tamoxifen, or aromatase inhibitors like anastrozole. And actually, anastrozole has proven very effective in some cases, especially in cases with Klinefelter syndrome, where it massively improved sperm retrieval when it was used pre-operatively. Also, gonadotrophins like FSH and HCG are used. All these medications are used either singly or in combinations. Sometimes we add antioxidants to them in a trial to improve the sperm retrieval. The second method of improving is varicocele, which is the core of our presentation today, and I will come to it very soon. And the next thing is we try to improve the methodology of testicular sperm extraction through introduction of microTACI in the 90s. And of course, we have Dr. Silber, one of the founders of the microsurgical testicular sperm extraction, which improved markedly the sperm retrieval rate in patients with non-obstructive azoospermia. So now coming to varicocele, there are some facts that we have to start with, that varicocele is present in 15% of normal male population. But however, it is more prevalent in patients with infertility. It's up to 40% in primary infertility and up to 81% in patients with secondary infertility. However, in non-obstructive azoospermia, it was documented to be present in up to 10% of cases. The pathophysiology of varicocelectomy, of varicocele affection of the testis, has been extensively studied in the literature in the past years. stating that increased active oxygen species, hyperthermia, hypoxia due to stagnation of the blood, reflux of metabolites and catecholamines from the kidneys through the incompetent veins to the testicles, and the disruption of the hypothalamic pituitary gonadal axis have been proposed. But the thing that we have to ask ourselves, can this pathophysiology cause the affection on the testicles to the extent of causing non-obstructive azoospermia? This is a question I think it still needs some research and still needs some explanation. We have various types of varicocelectomy. Previously, we were using the retroperitoneal or the Palomo approach, but it's now less favorable. Now we have the inguinal approach or the subinguinal approach, which can be either microsurgical or non-microsurgical. The microsurgical is the gold standard because it preserves the vasculature, the arterial supply of the testicle, because the artery is spared during the operation. So we prevent further insult on the testis, causing testicular atrophy. And we are sparing the lymphatics, so we are sparing the patient the complication of hydrocele. In this subset of patients with non-obstructive azoospermia, we already have a diseased testicle, a weak testicle. So we should utilize every way to not cause more insult. So microsurgical varicocelectomy is recommended in all cases, but especially in these cases, it is highly recommended to preserve the vasculature. When we think about doing varicocelectomy, there are guidelines that all the societies have agreed on. It has to be palpable varicocele during physical examination with patients with infertility, and the female factor is normal, and there is abnormality in the semen. Because as I said before, 15% of the normal population has varicocele. So we don't go for 15% of the whole men on the wall to do varicocelectomy for them. We have to be selective. We have to choose the patients who will benefit from our procedure. So now we come to the $1 million question. Should we do varicocelectomy in patients with non-obstructive azoospermia or not? To answer this question, we have to think, what are we aiming from varicocelectomy in these patients? First, we are aiming to recovery of sperm in the semen, hoping for spontaneous pregnancy, or at least to find sperm in the testicles, in the semen for ICSI, instead of testicular sperm extraction. Then the next level will be, if the sperm doesn't appear in the semen, I want to improve the surgical sperm retrieval. Then I want to improve the ICSI outcome. These are our aims. Coming to discuss the first aim, which is the presence of sperm in the post-operative ejaculate. The first case report on this entity was in 1955 by Tulloch, who presented a case of proven non-obstructive azoospermia, who showed a return of sperm in the ejaculate following varicocelectomy. And actually he did testicular biopsy following varicocelectomy to document the improvement in spermatogenesis. This was followed in 1979 by another study. It was a prospective study, and actually it's one of the few prospective studies done in this entity on 33 patients with azoospermia with different pathologies. They documented that 34% of patients were able to have sperm in the ejaculate 2 to 14 months following surgery. Sorry. Then in 2014, Dr. Schlegel had a retrospective study on 31 patients with non-obstructive azoospermia. He reported that sperm returned in 7 of these cases. But however, and on the day of ICSI, only 3 of them had motile sperm enough for ICSI, and the other 4 patients necessitated to go for another TACI. In 2006, that was another prospective study on 27 azoospermic men. They found sperm in the ejaculate in 9 patients, so in around 33% of cases, with different histopathologies. For example, hypospermatogenesis, maturation arrest, and germ cell aplasia, which was also reported by another study in 2007. It was a retrospective study on 19 patients, where they found 7 out of 19, so it's around 40% of the cases. They found sperm was also retrieved from patients who previously had hypospermatogenesis, maturation arrest, and germ cell aplasia. In 2008, it was another retrospective study that included only 6 patients with non-obstructive azoospermia, and in 2 of them, sperm were recovered in the ejaculate post-treatment. And then came the largest study by Yusuf et al. In 2009 on 79 patients, but unfortunately, he included 54 patients with true azoospermia and 25 with virtual azoospermia or cryptozoospermia. And he did a different technique. It was not microsurgical, it's modified macrosurgical, where he spared only the lymphatics and he ligated the artery and the veins. However, he reported that he had improvement in 34% where sperm could be retrieved in the semen. And he stated that the main predictor for success was FSH, which was found to be significantly lower in the patients who improved than the patients who didn't improve. And he stated that there was no improvement, no relation to varicocele grade, laterality, or testicular size. He also reported spontaneous pregnancy in 6 patients. 2 of them had spermatid arrest, 2 had hypospermatogenesis, and 2 had normal spermatogenesis. So it's appearing that he also included patients with obstructive azoospermia, which had biased the whole results. He stated that sertoli cell only and C1 arrest showed no pregnancy. Another study in 2009 on 10 patients, it was a prospective study. They found sperm in 3 patients, mainly with maturation arrest and hypospermatogenesis. And then a study by Dr. Ramadan Saleh from Egypt, together with Dr. Agarwal. On 31 patients, they found sperm in the post-ejaculate semen in 32 patients. They were either hypospermatogenesis or maturation arrest, whether early or late spermatid arrest. And this is one of the rare studies that reported improvement in early spermatid arrest. They also reported 1 case of natural or spontaneous pregnancy, and it was one of the cases with early spermatid arrest, the spermatocyte arrest. Then our group in Doha, we did our homework and we did our own study on the same entity. We did a retrospective study on 42 patients with non-obstructive azoospermia who failed medical treatment, because this is our regimen to give medical treatment prior to going for TACI in these patients. And they underwent a diagnostic biopsy at the day of varicocelectomy. We excluded abnormal genetics, cryptorchidism, obstructive azoospermia, chemotherapy, radiotherapy, or endocrinopathy, so as to avoid any bias of the data. We could find sperm in the semen in 11 patients post-operatively, which is in 26% of cases. And this table shows the semen parameters of these 11 patients with a mean count of 1.98 millions per milliliter. And fortunately, after 2 years of follow-up, none of the patients reverted back to azoospermia. We also tried to find predictors for improvement. We didn't find any effect for age, BMI, testicular size, varicocele grade, or even hormones. The only predictive factor was testicular histopathology, where hypospermatogenesis had 100% improvement of appearance of sperm in the semen. Maturation arrest, we showed no improvement, and with the sertoli cell, mixed sertoli cell, there was only a 27% improvement. On the other hand, another study, which was done on a small number of non-obstructive azoospermia patients, only 8 patients, they found or they reported no improvement following varicocelectomy. So we can see that most of the studies agree on that following varicocelectomy in non-obstructive azoospermia, sperm can be retrieved in the ejaculate. However, all these studies, including ours, have major limitations. The first thing, that there are no control groups. Second thing, that the sample size is fairly small. Some of the studies even included cryptozoospermia or severe oligozoospermia, and even some of them included normal spermatogenesis or obstructive azoospermia. The post-operative semen is mainly cryptozoospermia or severe oligozoospermia with counts around 1 to 2 million. So we have to counsel these patients to tell them that they may still need to go for IVF, and they have possibility of doing testicular sperm retrieval on the day of ICSI. Coming to the second aim, which is the effect of varicocelectomy on surgical sperm retrieval, there was the first study done by Dr. Schlegel in 2004. It was a retrospective one on 138 patients with non-obstructive azoospermia. He divided them into two groups. First group had prior varicocelectomy. Second group had documented varicocele but didn't go for repair. His overall success rate for sperm retrieval was 60%, and it didn't change in both groups. So he stated that there was no effect for varicocelectomy on these patients. Contradictory to this, another study was done in 2010 with the same methodology. They have 65 patients, 31 had history of varicocelectomy, and 34 had varicocele with no repair. They stated that there was significant improvement in sperm retrieval, implantation rate, clinical pregnancy, and live birth rate in the varicocelectomy group. They also stated a very interesting topic, that the patients who achieved pregnancy, the time interval between varicocelectomy and the TACI was significantly lower in patients who achieved pregnancy. It was 42 months in the pregnant group versus 80 months in the non-pregnant group. Another study stated the same fact, that 96 patients, again with a group of varicocelectomy and the group of varicocele that were not treated, they said that the sperm retrieval and the clinical pregnancy was significantly higher in the treated group, but the implantation rate was not affected. We recently presented an abstract in the EFRE in the 2020 regarding the same topic. It was a retrospective study on 227 patients with non-obstructive azoospermia, but we had a different methodology. Group 1 had varicocele, untreated, and Group 2 had no varicocele. We found no significant difference in surgical sperm retrieval between both groups. So we agree that it's possible that varicocele doesn't affect the surgical sperm retrieval. Due to the small sample size in all the studies, the meta-analysis is very important in such patients to study them. So we have two important meta-analyses. First one was done by Dr. Whedon and Dr. Lipschutz. It included 233 patients from 11 published articles. They stated that the sperm could be retrieved in the semen in 39.1%, and it was favored in late maturation arrest more than Sertoli only or early maturation arrest. The sperm count was the mean of 1.6 million, and the motility was a mean of 20%. Spontaneous pregnancy occurred in 6% of cases, while pregnancy by IVF was in 4.3% of cases, and they reported no intra or post-operative complications. The very recent meta-analysis was done by Dr. Estevez in 2016. It included 468 patients from 18 articles. He stated that sperm could appeared in the semen in 43.9% of cases, with a mean count of 1.82 and mean motility of 22.9%. The appearance, according to histopathology, it's favored in hyperspongiasis, 56%, followed by maturation arrest, 35. He didn't mention here whether it's early or late maturation arrest. He put them both in one entity. And the least favored is the Sertoli only 9.7%. And he denoted that the grade of varicocele didn't affect the appearance. On surgical sperm retrieval, the varicocelectomy had significant benefit for surgical sperm retrieval. And according to histopathology, again, the hyperspongiasis maturation arrest had the best results, while Sertoli only had the worst results. Regarding pregnancy, again, varicocelectomy favored pregnancy following TACI in these cases, but it didn't affect the live birth rate. So what we can conclude from this talk or this presentation? First of all, we have to agree that we are dealing with varicocele. So we have to put the proper indication. It has to be clinical varicocele, not subclinical varicocele, not a radiological varicocele, and not pressured by the patient. It has to be clinical varicocele to be done. Then we have to deal case by case. We are not dealing with a male, we are dealing with a couple. So we have to consider the wife age. If the female is younger age, for example, 26 years old, I may think of varicocelectomy. But if it is advanced age, like 40 years, I may think it over before providing him with this treatment. Also, the cost effectiveness. Some patients have money enough for one procedure. So we have to choose whether to go for varicocelectomy or he will go for IVF, because mostly he will go for IVF even after varicocelectomy. Last thing here, that we have to consider cryopreservation in all the patients if the sperm appear following varicocelectomy, because in 8 to 17% of cases, the patient will revert back to azoospermia. So varicocele may benefit some cases of non-obstructive azoospermia, mostly in hypospermatogenesis or late maturation arrest. However, it's less favored in complete surticule only and maturation arrest. We have to counsel these patients that the post-operative semen is mainly very few rare sperms, and he may still need to go for testicular sperm extraction. And most probably he will still have to go for IVF or EFRE. So we have to be very clear while counseling our patients for this, so as not to mislead them during our management plan. Thank you very much.